Welcome to Getting Better with Dr. Adam. Dr. Adam Silberstein is a clinical psychologist who has been working in the field since 1993. With a broad range of clinical experience, including state psychiatric hospitals, adolescent residential treatment with a trauma focus, the Department of Corrections, and in the addiction treatment arena. Adam is currently in private practice and serves as a clinical consultant and supervisor for a number of treatment centers.
I just had a really important conversation with Dr. Amanda Gutierrez. Dr. Gutierrez is the senior psychologist and training director at the DBT Center of San Diego and has a wealth of experience in training. But for the purpose of our discussion, we discussed the topic of suicide prevention and identification of issues around people who want to self-harm or hurt themselves. And she really brings a lot of experience. She was formerly the San Diego chapter president on the board of directors for the American Foundation for Suicide Prevention. And what was discussed and what I really took out of it was it's so easy to dismiss and sort of do a cursory investigation of people who are talking about something so serious like harming themselves, and the importance of asking the right questions in an in-depth way that provides the appropriate needed information to help someone, but also in terms of treatment, the critical nature of not reinforcing behavior that is actually hurting people and not allowing them to learn how to tolerate distress and cope with uncomfortable feelings. What it really said to me was, in addition to raising awareness and a sense that it's very hard to be a teenager in 2020 with a lot of vulnerabilities, clinicians like myself really need to become more skilled and in this area, and also know when to refer out to people who have the skill set of working with people who want to hurt themselves. So I hope you enjoy this.
This podcast is for general information and entertainment purposes only. This should not be considered treatment advice, nor is it a substitute for an individual treatment plan. If you have questions or concerns about your individual situation, it is strongly recommended you consult a licensed professional to talk about things that are specific to you. If there is an emergency, it is strongly recommended you seek treatment at your nearest emergency room.
Hi, I have the distinct honor to have Dr. Amanda Gutierrez on Getting Better with Dr. Adam, and very interested in the topic that we're going to be discussing. It's in the media to me. It's all over the place. I also work with young adults, and I'm hearing so much about suicide, the increased suicide rates, and there just seems to be, for me, way more attention. So much so that for me in the state of California, as a clinical psychologist, I am now mandated to take a course in this next round of license renewal, a mandatory course to improve my awareness and my competency in the area of treating individuals who have tendencies to want to self-harm or hurt themselves or kill themselves. And so I really thought it would be interesting to bring somebody on who has a background and an expertise in that. And I just want to give a little bit in the way of introduction. Dr. Gutierrez works in San Diego and is the training director at the DBT Center of San Diego. But for the purpose of our discussion, in addition to a wealth of training and experience, Dr. Gutierrez formerly served as the San Diego chapter president on the board of directors for the American Foundation for Suicide Prevention, and has been someone who's spent a lot of time and investment in the discussion and the training around suicide prevention. So welcome.
Thank you. Thank you for having me. It's a great honor to be here.
Yeah, it's pretty long-winded, but I want to take, I speak a lot, and so you'll deal with me. But my reaction to this is somebody who I started working in the field in 1993, I believe, is when I first started doing work. And, it was the way I was trained was sort of, ask certain like checklist questions. Do you ever think of hurting yourself or taking your life? Do you have an imminent plan? Do you have means? Do you have intent? What else is going on a little bit, and then move on to the next section of the interview. And my goal today is to expand on what once was, and to sort of explore how the field has evolved in this way, and also really take a good look at what's going on in the world of teens, young adults, and is it real? Is 13 Reasons Why? Is it something that is actually happening, that there's an increase in individuals who want to hurt themselves in that way? So that's just a good beginning of discussion.
Yeah, beautiful.
So why don't we take it with just what's your sense of business as usual in the field in terms of how we look at the subject and how it's progressed in your experience and what still needs work?
I mean, business as usual is what you talked about. Was, do you have the intent? Do you have means? Do you have a plan? And if that's no, then we kind of just move on to the next question. And I think suicide's really difficult because, I've worked with plenty of clients over the years that always have suicidal ideation or always have a plan in the back of their pocket, but have never acted and may never act. And then there's the flip side of that where you go down your checklist of factors or risk factors and they meet none of those and still end up acting and then dying by suicide. So suicide is a very, very tricky topic to cover in terms of what boxes do we need to check. I think a lot of times we spend a lot of time doing paperwork to just kind of cover ourselves and to avoid the risk of being sued or being held responsible for someone's death. And we don't spend a whole lot of time really kind of further exploring, people that might have an if-then plan, for example, like if I don't get into this college, then I'm going to kill myself. Or, if I don't get this boyfriend, then, so we don't spend a whole lot of time looking at some of the bigger factors that show up, especially with our adolescents who don't have the stability in their frontal lobe to kind of reach into that logic piece that things will change and things do evolve. It's kind of like, this is the worst thing that's ever happened to me and things will never get better. And so we have to look at it from a different scope when we're talking about teens versus adults who end up dying by suicide.
So if you're doing a training with a student who's brand new or doing a talk, where do you begin the discussion of suicide and how to help people?
Where do we begin the discussion?
Yeah, I mean, I'm saying so I'm looking at this as with a blank slate. I know the basic question, right, which is, do you want to harm yourself? And when I hear you talking about, hey, it's in another 4 years if I don't finish college. Let's say I want to finish college. If I don't finish college, I'd kill myself, right? And I'm a freshman, right? As a person working with someone, I'm like, I get that that's really important to you. I also get that it's not imminent in this moment. Right. So right. I have a breathe easy sort of, I don't have to make an emergency call. So what are, when do you say, hey, it's time, how do you parse out, it's time to get really busy and immediately attentive versus I just want to keep right on my radar that this is an issue and that could flare up down the road?
Yeah, I mean, I think especially when we're training students or talking to people that are newer with working with suicidal behaviors, even when someone does have a long-term plan, I kind of hear the saying, it's not a matter of if, it's a matter of when. They're definitely communicating a lack of resource. So if I tell you, if I don't finish college, I'm going to kill myself, there's a lot more to be said to that, there's an underlying message that I don't think that I have the skills to manage the distress that would go into, surviving a failure like that. And the truth of it is, or the reality of it is that there will probably be many failures along the way. So this person probably is going to be a risk for closer than 4 years out. And so it really is kind of digging down deeper of like, what would that mean to you, right? If you didn't finish college, then what? What does that mean? And usually those risk factors show up sooner in treatment than 4 years out. Which doesn't mean that it's imminent. It doesn't mean that this person needs to immediately, have some sort of safety protocol put in place, but it's something just to kind of listen to how our clients talk about what they feel like they're capable of doing. They get really stuck in this concept of ability, like I'm unable to do that. But can you learn how to do that? Can you learn how to tolerate more distress? What would be other options, or what would get in the way of you accomplishing that goal? And those are usually more of like the treatment targets.
What would get in the way of you accomplishing the goal of completing college, and then that becomes the treatment focus? So what I hear you saying is, if someone presents in, and we'll start off this way, in sort of a very loose statement with that doesn't pack immediate heat, right? And
Right.
says something like that, you, instead of just checking the box, no, they're good, right? You go right to, oh, I wonder why they think that there is any scenario, right, ever in any circumstance, even future oriented, where that may be an option. And you
Right.
immediately go to explore and unpack, why do you think you wouldn't be able to tolerate any situation down the
Right.
road in that way? So that's, and you start to identify the pieces that someone, the skill sets or the deficits that you could help skill build in the way to help that individual tolerate the potential stressors that will inevitably come along the way.
Yeah, absolutely. And really looking at their pockets of vulnerability and their deficits. If someone says, if I don't have a girlfriend by the end of my senior year, then I'm going to kill myself, right? Very logically, we might think, okay, well, let's see if we can get you a girlfriend, right? That'll keep you alive. But that's not the problem. The, the problem is that I need that to be alive. And what does that say about me? And what's wrong with me interpersonally that gets in the way of me having successful relationships, that then makes me feel like a failure, that makes me want to die, right? So there's the content and then the process underneath it that is usually much more valuable.
So when someone is giving you a more immediate alarm, like, uh-oh, right? Like that, that is a concern, and you unpack it and you identify what we just described. But when there's more of an immediate, uh-oh, on the,
Yeah.
I'm paying attention, I'm clinician, what do you see as something that reaches more of, gets your attention a little more than 4 years down the road, this is going to happen?
Again, that one can be really, really tricky to unfold because oftentimes, and not always, when people are still talking and communicating about, hey, I still really want to kill myself and here's my plan, they're still communicating and they're still expressing at least some desire of, help or wanting to be stopped. I think one of the scarier times, and this is hard for us clinicians, is when there's this kind of immediate flight to health, when suddenly everything's okay and
Mm-hmm.
everything's wonderful and treatment's really been really helpful, and you're kind of thinking to yourself like, has it? Like, you really haven't done much of anything I've asked you to do, and where did this come from? And so sometimes that can be a really risky time for people because they're getting their environment to back off and to not intervene. And so that can be a really hard time for clinicians to identify, like, is this person actually really improving in treatment and
Mm-hmm.
now has a quality of life that makes their life worth living? Or are they actually trying to get me to leave them alone so they can go ahead and kill themselves?
So you're saying if they're bringing it up, once it's on, because one of the ideas, if I really wanted to do it, if I was really determined, would I really even tell you? right?
Right.
If I was really, really had conviction about this, I probably wouldn't, I may not say anything, but the fact
Right.
that it's a topic of discussion in some ways is a reach for help. In many, I
Yeah.
mean, in most ways is a reach for help.
Yeah.
And if, as long as the discussion is in the atmosphere, right, there's a window or an opportunity for help.
Right.
So interesting if someone is, spontaneously healing, right?
Right.
After
Right.
talking about it so much, it gets that's just an area of concern
Yeah.
for the clinician. And especially if they're really sophisticated, they can say, wow, you're doing such a good job. Like it'll, sort of,
Right.
I'll feel so
Most
good that they're
therapists
doing
never
better,
had.
right?
Yeah.
I'll feel so good. So that's more in the they're it's on the radar, it's in discussion. When do
Right.
you go to high alert for you as a clinician and as a trainer? When do you get into, and I want to hear also about, when do you get into high alert, and when do you start to ask lots more questions, and what those are?
Um, it would depend on the patient and really knowing the people. Oftentimes, when people come in and they work in a clinic like at the DBT center, most people show up on our doorstep already having experienced non-suicidal self-injuries, suicide, at the very minimum ideation. Many people have attempted. So it's kind of on the table already. But I think when you work in a less clinic that's less focused than that, it might just be like the checkbox sort of thing. But you really do want to kind of dig down a little deeper and talk more about, if someone says, I've had suicidal ideation, tell me a little bit more about that. When does it show up? Why does it show up? And what do you do with it? So some people are like, oh, I just ignore it. I never really actually want to die. And other people are really, really controlled by their thoughts and think, I have to stay in therapy or in a hospital or something in order to be safe. Um, so, you know, when we hit high alert is usually when like all the factors kind of come together. Like this person's really acting a little out of character. They're not returning my phone calls. Let's say I had someone who was really consistent in treatment, and then they have a huge vulnerability factor that shows up. Like they get fired from their internship or their boyfriend breaks up with them, or something that just like kind of puts them at a higher level of risk. Um, then we can kind of really, really dig. And I think a lot of times clinicians are scared to rock the boat, and there's that myth that if you talk about suicide, it'll make people more suicidal. I think most people know that not to be true at this point, but we still really tiptoe around the questions of like, what's going on with you? Why are you suddenly telling me everything's okay when I know everything's not okay? And so really asking the hard questions so I can assess clearly what the risk actually is.
So what I learned in this is, or how it's landing on me, what you're saying is don't just leave the question alone of ideation, but and I get it. I'm not actually going to do it is one path, but go deeper. Don't for me ask what circumstances increase these thoughts, right? When what types of things can you imagine, even escalating? What types of scenarios or vulnerabilities would increase these thoughts? And what kind of weight do they have with you?
Mm-hmm.
Right? Do they pull you, or do what is your experience in terms of distress level? How much do you can't stand it, or you kind of see it? Yeah, that's just my head, no big deal. Like, where are you at with
Right.
these thoughts? And if I already have somebody coming in who's had suicidal ideation, what I'm hearing is be prepared, because life is in session, right?
Right.
And some vulnerability will happen. And if I'm doing a good assessment, I'll have an idea of how the mechanism of their ideation in general.
Right. I think also in asking, continuing to dig down and unpack the questions, if someone says, yeah, I've had a plan, I'll ask very specifically, like, what plans have you had, either now or in the future or in the past that you thought it might actually work? And I think where a lot of clinicians may stop is if they say, oh, I might overdose, or I don't know, jumping from a bridge or something. And they're like, okay, they jot those few things down and they move on. But I would want to know on what bridge, How, have you driven to that bridge? Have you scoped it out? Have you looked over the edge? Do you know where you would park? So I want to know how close this person has actually ever gotten to that plan versus it just being this like, I don't know, they said they'd overdose. I've worked with people in the past where you keep digging, and then you come to find that this person has stockpiled, a bazillion lethal pills. And it's like, oh, I'm glad I kept asking questions, because if I had have just left it at, oh, I'd probably overdose, I wouldn't know that you had 500 of this medication that could easily kill you that I now need you to bring to a pharmacy and get rid of. So I think we just have to keep asking questions and to not be scared to step on toes.
Right. I had a prior podcast on, it hasn't been released yet, on sex positivity, on like overuse of cell phones and just like discussions people don't want to have at the table.
Yeah.
Like if I'm using my cell phone at the table, I don't want somebody to tell me, hey, you really shouldn't do that. But the even harder one is like talking about sex, like really talking about sex. It was on sex positivity and just things that seem, discussions that people want to avoid. And I don't even know if the cell phone should count. Maybe I made a mistake there. But this one is, this is a very, very tough discussion. I think I can see what you're talking about, the instinct to just want it to end there. Oh, you thought of jumping off a bridge? Check. Right? Like, I don't want to know if you actually, what the details of that are. So in light of that, as someone who trains and has your experience, what makes you go, oh my God, this really needs to change. This clinic, these providers really need an overhaul. I really wish they were doing things different. What, in addition to asking more questions, what makes you kind of go cringe?
Oh, that's a loaded question.
And not in a mean way.
I think oftentimes what people do around suicidality actually ends up making it worse. So I've had more clients than I can count that during this initial intake will tiptoe around things like suicidal ideation or, thoughts, plans, intentions. And I have to pause them and be like, look, I need you to be completely transparent with me about this. We're going to talk a ton about suicidal ideation and urges and behaviors. I'm not going to hospitalize you. I'm very unlikely going to hospitalize you. And they're like, oh, okay, well, let me back up a little bit. Here's really what's going on. Because oftentimes they'll go see, kind of a layperson clinician that will immediately hospitalize because of suicidal ideation or because the person's self-injuring or because they say, yes, I've had a plan. Yes, I've had intent. That doesn't mean that they're an imminent risk. They just aren't asking the right questions. And, we look at the data statistically, there is not one single study out there that suggests hospitalizing someone who's suicidal makes them less suicidal. It's actually the opposite, right? Coming out of a hospital is a really high risk time. And so a lot of times when I work with someone and they're like, oh, I've been hospitalized 6 times in the last year, that will make me cringe. I'm like, why? And they're like, oh, because I told a therapist I was suicidal, or I told a therapist that I had self-harm. And, so those sorts of things. I think that there's just this, we live in a sue happy society where nobody wants to be sued and nobody wants to be held responsible for someone's suicide. And what we end up doing is this repetitive avoidance cycle of like, oh my gosh, you're suicidal, go inside a hospital, avoid some more, come back out. Let's just keep doing this. And the person actually ends up getting worse, particularly with their adolescents. There's a set of, data that suggests the earlier they start getting hospitalized, the worse their long-term outcomes are. So we really, really, really want to help parents and schools and those people really kind of tolerate their own distress around not doing something that's going to make the situation worse.
So I'm clear. The reflex of sending somebody to the hospital, while there's a protective factor if it's imminent, right, doesn't necessarily mean that after 72 hours I come out feeling like I just went to a spa and refreshed. Right? Right? I'm not coming out like, oh, that was great. I'm actually, you're saying it actually over time increases risk. It doesn't lend to symptom reduction. So that you're saying to the people you train, do everything you can to do a good assessment so that doesn't happen. So let's take adolescents. Let's in terms of a vulnerable population, right? Tell me about, are they the most vulnerable population in terms of age bracket right now?
Yeah, they are actually. I did a little review on statistics to make sure I wasn't
Making stuff
rambling
up?
off
Yeah.
random stuff. But actually, when you carve out the age group of 15 to 24, that suicide is the second leading cause of death for that age bracket, looking at about 6.8 deaths per 100,000 people, particularly with Black girls and boys, looking at a 73% raise in suicides. So our adolescents are climbing pretty rapidly in terms of the suicide rate. And as a culture and a country as a whole, our suicide rate is rising. It's still lower than other countries like Russia, China, but the trajectory isn't good. It's not looking good, being that suicide in the U.S. is the 10th leading cause of death, and that younger bracket seems to be growing pretty rapidly.
So the number two leading cause of death in adolescence and on the rise. So just more of a broader discussion. Why? What do you? I mean, I know you can't say this is exactly why, but what are the people who are interested in this thinking?
There's a lot of reasons why. The myth that there's only one reason that someone dies by suicide is a myth. So you'll see that in the media, right? Teen dies by suicide after breakup, or teen dies by suicide after failed a test, right? And it gives this idea that there was one causing factor to that, which is not true. You have to have many other factors that go into that final decision to take your life. I think as a whole, if we're looking at what may be causing this rise in suicidality, I think our first and foremost is access to care. So people having accessible, affordable mental health care is our number one problem, right? We say early intervention is the best intervention, but a lot of times people don't have access to treatment, or they, quote unquote, don't have great insurance, or they can't afford to get really effective treatment. And so, that adolescent goes to their school counselor and says, I'm feeling suicidal. And the knee jerk is, well, they need a therapist. Not all therapy is created equal, and not all therapy is created to manage suicidality. So, they go see some kind of talk therapist or support therapist, and nothing actually ever gets resolved or gets better. They never really learn the tools they need to learn. So I think there's a lack of education of like, what therapies do I actually need if this is my primary problem? If suicidality and self-harm is my primary problem, I can't just go see a talk support therapist, because they're not trained to manage this, and will often do things to make it worse through reinforcement and hospitalization and those sorts of things.
So when you say they do something to make it worse,
Mm-hmm.
what do you reference? What would, besides increased hospitalizations, what's another example of making it worse?
Let's say we have an adolescent who's self-harming as a form of communication, right? I don't know how to communicate to you my needs or how I'm feeling. And so what I do is I self-harm. And when I self-harm, what I get from my therapist is an increase in contact. My therapist calls my parents and tells them exactly what I need. They call my school, tell my school exactly what I need. And I get a lot of warm and fuzzy cuddles, support. So I get everything I needed without having to ask for it. Over time, results in this person having an even larger skill deficit in communication, and thus needing more of that behavior. So we've worked with plenty of schools and teachers or people that refer to us, where we're like, okay, here's what you got to stop doing. When this person comes to you and says they've self-harmed, we've identified that it's likely communication. Let's ask them to communicate. What is it that they need? What is it that they feel? What is it that they want? Versus kind of doing this kind of trial and error and doing everything for the person, which then just kind of reinforces the idea that I can't do it anyways.
So the therapist in that, and the school and the helpers become a means of enabling
And reinforcement
and coddling the behavior, which is the behavior that is not being developed is the I need to learn how to ask for help, and we're creating a situation where I'm sort of at your beck and call, and you don't have to do anything because I'm approaching you from a place of fear,
Right.
You self-harmed, you used, you even referenced self-harm. So therefore, I'm going to be hyper vigilant in a way which actually is harmful to you.
Right.
Interesting.
Right. I think there's a couple other reasons why. And I think the second one, or, one of the other ones is access to lethal means. Please don't send me a bunch of emails about your Second Amendment right. I get that. Um, but the US does have more guns per capita. And we know that over half of suicides are via gun. And having a gun in the home in and of itself is a risk factor. So when you have
For
access,
adolescents.
yeah, for anybody. But with adolescents, you add that kind of like non-fallibility. Um, you know, they don't really grasp how final things like death are. So, you have access to a lot of lethal means, guns being the most lethal. And we are having more and more people die by suicide via gun. In other countries where they have limited access to lethal means, like England, for example, was having a lot of death via carbon monoxide. They switched to a less toxic gas and they saw a 40% decrease in suicides. So I think access to lethal means, particularly firearms, is a huge, huge reason that we're seeing an increase in suicides among all people, but adolescents as well.
So my dad has a gun or my mom has a gun, right? That is an increased risk factor. What
Yes.
about social media and the whole culture of the teen and bullying and pressures? Is it I know that it's an easy reference point that's a major difference, and in some ways I look at social media that people who are more marginalized have access to different communities in a different way. It's not all bad, but
Right.
how does it pertain to this discussion, if it does at all?
Oh, it definitely does. Our adolescents really, I think, really, really have it hard. I mean, if there's anything in this world I am grateful for, is that there was not social media when I was in high school or college. Like, thank you. um, but, you think about these kids that are already vulnerable and go on social media, and there's this kind of like depression via comparison, right? As adults, we can look on someone's social media page and say, I can probably understand that they don't have the happiest marriage in the whole wide world. That's just what they're posting on social media, right? Or I see every other day a friend's buying a house and standing in front of it with a set of keys and a "we sold" sign, and it sucks, right? Like, you're like, oh, I really want to buy a house, but I live in Southern California. And but teens don't have the frontal lobe to kind of reason and logic all of that out. So they really get stuck in this kind of all or nothing thinking of like, everybody has this huge group of friends, everybody has a boyfriend, everybody's going off to college. And so it kind of becomes this depression via comparison of like, my life doesn't look like that. It's never going to look like that. And, so if I'm already vulnerable to depression and anxiety, here comes more of that. I think another big issue with social media is that, one of the risk factors for suicide is public shame. If I have been publicly shamed about something, and with social media, as adolescents, you're supposed to be making poor decisions and learning from them, right? We all did. But your poor decisions today get posted online and everybody gets to see it, and everybody gets to talk about it, and everybody gets to post about it. And so there's this huge flare up of public shame that can really, really be a huge vulnerability factor for people.
So public shame is considered a risk factor in terms of the percentage of people who do it. That is one thing that should be assessed if you have an experience of public shame. So if you've been, if there's an article written about your going to jail and everybody knows you as a character who was shady, that is a risk factor. And so
Absolutely.
you're constantly having hits of, or at least anticipation of a potential shaming event on social media, and you're vigilant for that. So that's a tough thing. What about, I don't know if you ever see it, but suicide pacts with teens and sort of
Yeah.
a collection of kids, sort of identifying in that space. Do you know anything about that?
I don't know a whole lot about that. And fortunately, knock on wood, I haven't run into that too much in my own practice. But I think, if you look at adolescence, what's most important to you around that time in development is your peers. And so I think that idea that, our adolescents are more disconnected interpersonally and more connected via the web than ever before. And so if I want to feel connected to people, and this is the way that I have to do that, I might jump on the bandwagon, just as a way of feeling part of something that,
And what's interesting in terms of brain development, what you were reflecting on is if I don't have the resources yet to, in development to access perspective, right? I'm going to go where I feel comfortable
Mhm.
and where in a perspective I know. And if identity suicide or identity darkness is something that I can wrap my head around, right? I'm less likely to examine it from a more of an observing perspective in teenage years.
Absolutely. Absolutely.
So hence and I noticed this in the teen space is identity sick
Yes.
experience, and it's not faking. I think that it's not, oh, they're just being adolescent, and they're so adolescent. I don't like it when people say they're so adolescent. Well, they are adolescents.
Right.
Kind of annoys me, but that is an experience, and in terms of the way you would assess and what I'm hearing, it's like, oh, why are you gravitating towards that identity? What is
Right.
missing? What is missing? I want to ask you a question about the statistics. As far you may or may not know this, when they assess death by suicide,
Mhm.
does overdose count? Do they include overdoses in that statistics? It's hard to know if someone is intending to use drugs to kill themselves or if it's just a casualty of using drugs.
Yeah. I don't think, unless there's some sort of identifying factor, like a note left behind or someone saying, yeah, this person told me they were going to overdose on heroin tonight. I don't believe they count as suicides because there is no way for you to tell. It's kind of the same with when there's a high figure suicide in the community, Robin Williams or someone like that. There's a increase in single person car accidents. And so it's like, you just don't know. It's like, oh, is that just a coincidence? Causation and correlation are two very different things. So, but we do know that there is a trend there. So it is really hard to say if this person died by an overdose, if that was intentional or not.
Right, and it may actually underrepresent the numbers. Meaning, if somebody walks into it and says, "I don't care if I die," right?
Yeah.
And when I work a lot with addiction, I see people just reckless abandon, and whatever happens, happens.
Mhm.
I
Yeah.
had someone say to me, "Hey, I heard the fentanyl in the valley is killing people. I got to try it." Right.
Right.
So that's
Right.
that's an interesting, I don't know exactly. I mean, there'd be more to unpack there, but
Yeah.
it may be an underrepresentation. I have a question about all this discussion. So here we have a lot of attention. There's more efforts to raise awareness. Does it actually help?
That's a tough one too, because, we have a certain set of data, right? That tells us who has died by suicide that we know is actually a suicide. That doesn't usually include overdoses, single car accidents, things that kind of fall into the parasuicidal community, which is what you were just referring to, of like, I'm not actively trying to kill myself, but if that was the result, I'm fine with that. So drugs often fall into that, really severe eating disorders, reckless driving, um, So, there's a huge movement, particularly through the American Foundation for Suicide Prevention, of prevention, and how do we, have researches and outreach and education and survivor skills and survivor resources. But suicide is still on the rise. And so it is really difficult to say how many lives have been saved versus how many lives have
Yeah,
been
how
lost.
can you really measure that? But
Right.
I think one of the questions is for the teenager, right, whose identity sick, like we spoke about, right? Does
Hmm.
the discussion, in your opinion, with teens in particular, raise an alarm of, oh, that's a menu option, right? Is there a sense that the discussion is in some way contributing to the problem, or in teen population in particular?
Yeah. I mean, it's really hard to say because I think our teens, um, again, are more disconnected than they've ever been. And so sometimes when I tell someone, oh yeah, I'm suicidal, and now I have a short term group of friends and a counselor that checks in on me, it's like, oh, well, that worked. And what that does is it just reinforces in my brain that that is how I get my needs met. And that could absolutely turn into, legitimate suicidal ideation and behaviors. And there can be this whole trajectory that's really unpredictable.
So, in that spirit, what is your idea of a student that you work with? You're like, oh, we've talked about what doesn't work. What's an example where you're like, wow, this is wonderful. What a great assessment. I love what they looked at, and I love the factors that they addressed. What makes you just not the opposite of cringe?
Oh gosh, that's a big question. I mean, I think a lot of the stuff that we've talked about really being, you know, just kind of being fearless, asking the really difficult questions, really digging down. Like, I don't want to know that they just had a plan for overdose. I want to know on what, from where, from who, where are they getting it, where would they store it, how close have they gotten. Like really asking the big questions. I would, if they told me they were going to jump from a bridge, I would want to know what bridge, at what time of the day, have they ever driven over there, um, and that sort of thing. It's not just about the the quantity of suicidal ideation, but it's the quality and the momentum, right?
So you're
I like it.
impressed with a student who isn't sloppy and is
Right.
going to do in-depth assessment and keep asking questions. You mentioned earlier the idea of public shame being a risk factor. What are the
Mhm.
risk factors that you want people to be, attentive to in the teen
Oh,
population?
yeah. I mean, I think some of the typical ones: depression, anxiety, substance abuse, feeling disconnected, feeling like a burden, that kind of if then, and this kind of underlying theme that like things cannot and will not get better, that things are always going to be this way. I think something to really challenge is when you have a client that says, I want to die because things will just be better if that happens. And, I usually follow that up with like, how do you know that? Show me a research article that suggests life is better after you've died. Show me one piece of evidence to suggest that. You know,
uh-huh.
that's a belief. That's a belief, right? We have a lot of beliefs. I
So,
believe in unicorns, like, so really challenging that because the adolescent brain doesn't know how to do that.
So a rigid attachment to a belief with conviction without data, right?
Yeah.
Right?
Yeah.
A lot of conviction without data when it comes to I won't be okay situations. If that happens, I won't be okay. That is a better option, right?
Right.
Is the good clinician is going to be challenging that assertion, and it's not. I'm hearing also that you believe strongly, and it totally makes sense that it's not a for the people who tend to have been hospitalized multiple times, it's not just bread and butter generalist type of treatment. There's a skill set in terms of learning how to address these issues in a competent way.
Absolutely. And I think that kind of there was a another factor that, when I was kind of thinking about this before interviewing today, that idea of, when people come to the DBT center, one of the things they learn how to do is regulate their emotions and tolerate distress and manage interpersonal effectiveness, stay in the present moment. And a lot of our adolescents come from this culture of overindulgence and the removal of barriers. Madeline Levine wrote this amazing book called The Price of Privilege. And it's basically about how we're seeing this crazy epidemic of rates of depression and substance abuse and anxiety disorders in our adolescence, and really kind of linking it back to them being overindulged with material and underindulged with having to deal with natural consequences and barriers. So everything gets removed for them. So, you get a bad grade, parents call the school and get it removed. You don't want to do your test on Friday, parents call and have it moved to Monday. There's all these things that when our adolescents are then set free, let's say college, they've never been told no before. They've never been told they can't have an extension, and they don't have the skills to manage it. They don't have that distress tolerance or the ability to regulate when things are not going exactly how I want them to go. And so we see a lot of that where the parents, from a really great place, right? They just want their kids to be happy and healthy and have all the best things, have actually removed really important developmental milestones of like getting through the tough stuff. I've had parents who've intervened with friendships, like, oh, you need to be this person's friend because they struggle with depression, or don't break up with him right now, he's really depressed. And I'm like, oh my gosh, like those are things that like would really help someone while they're really unfortunate, and nobody likes going through a breakup. We all did it. And right now, a lot of our adolescents are not being forced to deal with any of that because it's all being removed.
So no is not a bad word.
No.
Right. No is not a
No.
bad word. Last question for you, and I'm just going to ask you to speculate. This show, 13 Reasons Why, and what does it represent to you in terms of, it had such popularity, or has such popularity, and I think, this isn't about attacking it as good or bad. This is more about what's that about?
Oh, that show. The show is very entertaining. I watched it. I think some of the problems with 13 Reasons Why, particularly season 1, was that they ignored all of the professionals' recommendations on how to effectively and responsibly discuss a really difficult topic like suicide. And what we saw was a rise in suicidality because of the contagion effect. And I think one of the things that they really failed at in the show was to accurately reflect mental health, right? The main character, Hannah, seemed to be great, right? Things were fine. She had a great family. They never showed her struggling with depression or anxiety or any of the factors that would go into someone taking such a drastic means. There were some things that happened to her along the way, but it was a really ineffective description of what someone who ends up making that choice would look like, I think was one of my biggest gripes with the show. And them showing the suicide and all of those things was just really irresponsible. I know they tried to recover the second season and talk about it more effectively, but now they have second season of it really being glorified, right? There's now this person is so like sought after. And so I think when you're dealing with a really vulnerable population that feels disconnected and isolated, and they see Hannah now being this like really glorified figure, sometimes that feels attractive. Like I would love that. I would love for someone to miss me and to wish I was still here. And so reporting on such a touchy topic is so important and has to be done really carefully.
So it's interesting to me, and I'll wrap it up, is that the idea of a vulnerability, it's not going to be a standalone based on what we spoke about. So you're not going to have a breakup, and that's I am this paradigm of mental health, and I am just a walking, self-esteem machine, and then, I had a breakup and I killed myself. It doesn't go with people who want to hurt themselves.
Right.
That's not the picture. And again, it goes back to competency and doing the discussion justice. I think that there is a real training need for what it means to have this expression of mental health issues. So I really, really liked the language you used and the the nature of this discussion. I just think it's really important. If someone wanted to reach you and contact you, what is the best way to engage you in discussion or access help for our listeners?
Yeah, absolutely. I would encourage you to go on our website. So the DBT, so Dog, Bear, Tiger Center of San Diego. And you can get resources and contact information there. I'm going to be on leave until June. But after June, if you want to email me at amanda@dbtsandiego.com, I will be accessible at that point too. If people have questions, if DBT is right for them, whatever it is, neither of those are crisis hotlines.
Mm-hmm. And for those people, in a similar note, for just general resource, is there any place that in terms of information and how to learn more about this, is there any resource you would recommend?
Yeah, I mean, I would definitely look at the American Foundation for Suicide Prevention. AFSP.org has a lot of how to get involved, how to take action, resources, statistics, and support. So I would definitely reach out and look at that resource as well.
Dr. Amanda Gutierrez, thank you so much for this great discussion, and good luck to you in your endeavors. And we really liked having you on. Thank you so much.
Thank you so much. Thank you for having me.
This podcast is for general information and entertainment purposes only. This should not be considered treatment advice, nor is it a substitute for an individual treatment plan. If you have questions or concerns about your individual situation, it is strongly recommended you consult a licensed professional to talk about things that are specific to you. If there is an emergency, it is strongly recommended you seek treatment at your nearest emergency room.